Thank you. We referred before to the low-dose FSH treatment for PCOS, so now we're going to go into it in a little more detail. Why is PCOS different from any other ovulation induction? The fact is that the polycystic ovary has a greater sensitivity to gonadotrophin stimulation. And so when the ovary just smells one ampoule of FSH, then you get a sort of explosive response of the follicular development. Why does this happen? As we said before, there are 6 times more follicles there. And these aren't dead follicles, they're not atretic. And they will all respond to FSH because they all have FSH receptors. So that what happens, we have this large cohort of follicles which are all capable of response if you give FSH. And we've shown this before, the large number of follicles that we have there. Now, when I first learnt the conventional way of giving gonadotrophins, this seems like about 100 years ago now, then this was the way I was taught how to do it. We would start off usually with 150 units and give this for about 5 days. If there was no response, then we'd go up by what was then 1 ampoule, which was 75, and have a look again, another 5 days, and go up. This is the conventional way of doing it. And when these results were summarized using a conventional program, then we saw that there was a good conception rate, but the multiple pregnancy rate was 34%, and severe hyperstimulation 4.6%. Now in 2012, this is completely unacceptable. And so we had to look for a way of getting these same results, but without all these complications. Why are the complications there? Because of the multiple follicular development, and this is what's giving us a very high multiple pregnancy rate and a far too high incidence of severe hyperstimulation. And this was the way that we do it. We start off low and it's slow. It's the low and slow chronic low dose protocol. Low dose, never more than starting with 75 and usually around 50. And we continue that without interruption, without changing the dose for 14 days. If after 14 days there is no follicle greater than 10 millimeters, then we go up by just half the starting dose. And this we continue for a minimum of 7 days, again without changing the dose. No response, and again we go up by just half the original starting dose. So this is a low and slow protocol, and the whole idea is to get one follicle that ovulates. And this, of course, will avoid all the complications that we have with the conventional protocol. And when, a while ago now, we gathered the results for the low-dose gonadotrophins, and we're still maintaining a good pregnancy rate. But you can see here, this is the key figure here, the number of cycles that we had with just one ovulation was over 70%. And this is the reason why we almost completely eliminated ovarian hyperstimulation, and why the multiple pregnancy rate that was 34% with the conventional program is now 5.1% using the chronic low dose protocol. Now, as soon as you have a good idea, then somebody tries always to make it even better. So they said, well, what you've shown us and what we are using is the step up. Why not use the step down? And the reasoning behind this was to try and make it more physiological, because FSH is at its peak during the menstrual cycle and eventually goes down when the estrogen and the follicular size starts going up. So the whole idea said, well, why not use a step down, maybe it's better. So the only way to find out was to do a randomized trial, which was done in France, and they compared the step up with the step down protocol. All the women were clomiphene resistant, 83 patients, they were randomized, 3 cycles each of either a step up or a step down protocol. And this is what they used. They started with 50 for 14 days, went up by 25 if there was no response, and so on. And in the step down, started with 100 units of FSH until they had one follicle of 10 millimeters or more, and then stepped down by 25, and after 3 days stepped down by another 25. Now, we won't go into all the details, but the conclusions were very clear that the step-up protocol is very much safer and it's more efficient than the step-down. So the one I showed you originally is the one to use because it gives you a lower rate of overstimulation, a higher rate of monofollicular cycles, and a higher ovulation rate. So use the step-up and not the step-down. How can we improve the results even further? Can we lower the starting dose? Can we change the incremental dose rise, which is very small? Shorten the duration of the starting dose from 14 days to 17 days, which was one of the questions that was asked before? Or does it make a difference which gonadotrophin preparation you use? The starting dose doesn't make very much difference as long as it's low. This is just one example when a starting dose of 37.5 units compared to 50 units, there was actually no difference in the results. So it doesn't really matter, except with the 50 units you may be using a little more FSH, but clinically no difference. What does matter is the incremental dose rise. You must keep this low and never more than half the original starting dose. And this was just one example when a dose rise of 50 units was compared with a dose rise of 25, both of them starting with 50 units a day. And you can see that in yellow, the smaller dose rise was much more effective as regarding ovulation rate and monofollicular cycle rate. We even went one step further, and we used a dose rise of just 8.3. This was utilizing the Purigon pen, in which one click could give you a dose rise of 8.3. And we used this protocol of 50 for 7 days, going up just by 8.3 units if there is no response, and then again by the same amount after 14 days. And we tried this on 25 women with clomiphene-resistant PCOS over 69 cycles. The treatment period was fairly short, just 10 to 11 days. Total dose of FSH was relatively low. We only had one cycle cancellation for overstimulation out of the 69. We had a monofollicular ovulation rate of over 82%. 20 of these 25 became pregnant, and 16 of the 25 had live births. We had one set of twins, not sure how they got in there, and of course no cases of hyperstimulation. And you can adjust this low dose protocol according to your own population. And this was the case in Vietnam, where women are generally smaller with a lower BMI than we're used to either in Western Europe, the Middle East, or indeed in India. And this is just one example. 183 patients with clomiphene failure, all with PCOS, and they all had a normal or a low BMI. And they started with 25 units for 14 days, went up by 25, and after 5 days went up, and this was very good for their population. Again, a fairly short duration. Total FSH dose was fairly low, very high ovulation rate, 62%, just had one ovulation, and a good clinical and ongoing pregnancy rate. So you can adjust this protocol according to your individual population. Now, in Israel, my patients are usually very impatient, and they say, what, you're going to give me FSH for 14 days and you're not going to change the dose, and they may well disappear to the doctor next door. The only way to find out is if we shortened it to 7 days instead of 14 days with the initial dose without changing it, would this make a difference? So we did the trial, and 25 patients we started changing the dose only after 14 days, and in the other group of patients, equal number, then we changed up the dose after 7 days. And you can see that if you change up after 7 days instead of 14, then you use less FSH for a shorter time. But this comes at a price, and the price is the number of mono-ovulatory cycles. If you change up after 14 days, if necessary, you get 74% mono-ovulatory cycles. After 7 days, you get 60%. That makes a difference. And the difference was shown here, because we had no multiple pregnancies if we change up after 14 days, and 2 if you change up after 7 days. So this worried me a bit, so we continued with this. No multiple pregnancies if you change up after 14 days, 6 out of 29 if you change up after 7. So since then, we only change our dose after 14 days. But you shouldn't worry too much, because if you start, for example, with a dose of 75 units of FSH and you don't change it, then 90% of your patients will get to the criteria of HCG within those 14 days without you having to change up the dose. So there is an accumulative effect of this FSH that will work without you having to change up the dose. Does it matter which preparation you use? Well, you all know the list of gonadotrophin preparations that are on the market today, and it seems to be growing by the day. And I'm going to cut this part short because I can tell you it doesn't make any difference at all in low-dose gonadotrophin therapy which of these preparations you'll use. Just to paraphrase Frank Sinatra, it's not what you give, it's the way that you give it. So to summarize, only a low-dose protocol should be used for ovulation induction with gonadotrophins in PCOS. There is today no excuse for using other protocols which are going to give you a complication rate. You should use the step-up protocol rather than the step-down, because that's safer. And the key to the success here, and is a very successful way of treating, you should be getting between 70 and 80% clinical pregnancy rates over 3 cycles if there is no other factor causing infertility, and that is a very high rate. So the key is using a small starting and a small incremental dose rise, no dose change for 14 days. Thank you.